Hello and welcome. Today, we're diving into a less common but serious complication of a parasitic infection, schistosomiasis-associated nephropathy. This is a kidney disease that develops as a result of chronic schistosomiasis infection, and understanding it is crucial for effective diagnosis and management, particularly in endemic regions. We will explore the causes, mechanisms, symptoms, diagnosis, treatment, and prevention of this condition. Schistosomiasis-associated nephropathy, at its core, is caused by infection with parasitic worms called schistosomes. Specifically, Schistosoma mansoni and Schistosoma hematobium are the most frequent culprits. These parasites reside in freshwater snails during part of their life cycle. Humans become infected when they come into contact with contaminated water, allowing the parasites to penetrate the skin. The worms then mature and reside in blood vessels, with Schistosoma mansoni typically found in the mesenteric vessels of the intestines and Schistosoma hematobium in the venous plexus of the bladder. The eggs laid by these worms initiate the disease process, contributing to kidney damage. Rarely, other species may cause renal complications. The development of nephropathy isn't directly due to the worms residing in the kidneys. Instead, it's primarily an immune-mediated process. The schistosome eggs become trapped in the liver, spleen, and sometimes the kidneys. These trapped eggs trigger a strong inflammatory response as the body attempts to eliminate them. This chronic inflammation leads to the formation of granulomous clusters of immune cells around the eggs. These granulomas deposit immune complexes, particularly IgM antibodies bound to schistosomal antigens, in the glomeruli, the filtering units of the kidneys. This immune complex deposition activates the complement system, further exacerbating inflammation and causing glomerular damage. Over time, this damage leads to thickening of the glomerular basement membrane, mesangial proliferation, an increase in cells in the mesangium, and ultimately proteinuria, the presence of excessive protein in the urine, and kidney dysfunction. Schistosomiasis, and consequently schistosomiasis-associated nephropathy, is primarily found in tropical and subtropical regions of the world. The disease is endemic to many countries in sub-Saharan Africa, parts of South America, the Middle East, and Southeast Asia. The prevalence of schistosomiasis-associated nephropathy mirrors the distribution of the underlying schistosomiasis infection. People at greatest risk are those who live in or travel to endemic areas and are exposed to freshwater sources contaminated with the parasite. This often includes agricultural workers, fishermen, and children who swim or play in these waters. The disease is often associated with poor sanitation and limited access to clean water, which contribute to the persistence of the parasitic life cycle. The signs and symptoms of schistosomiasis-associated nephropathy can be subtle, especially in the early stages. One of the most common and earliest signs is proteinuria, which may initially be detected only during routine urine testing. As the kidney damage progresses, individuals may develop more noticeable symptoms such as edema or swelling, particularly in the legs and ankles. Hypertension or high blood pressure is also a frequent finding. In severe cases, kidney dysfunction can lead to symptoms of chronic kidney disease, including fatigue, loss of appetite, nausea, and shortness of breath. In children, schistosomiasis and its associated nephropathy can lead to stunted growth and development. Diagnosing schistosomiasis-associated nephropathy requires a combination of clinical evaluation, laboratory tests, and sometimes kidney biopsy. The diagnostic process typically begins with a thorough medical history and physical examination, focusing on potential exposure to schistosomiasis. Urine analysis is crucial for detecting proteinuria and hematuria, blood in the urine. Blood tests are performed to assess kidney function, including measurements of serum creatinine and blood urea nitrogen (BUN). Stool or urine samples may be examined for the presence of schistosome eggs, although this may be negative in chronic cases with established nephropathy. Serological tests which detect antibodies against schistosomes can also be helpful. Kidney bioinvasive is often necessary to confirm the diagnosis, assess the extent of glomerular damage, and rule out other causes of kidney disease. The biopsy reveals the characteristic features of immune complex deposition and granuloma formation within the glomeruli. While schistosomiasis-associated nephropathy is generally considered a single entity, it can present with varying degrees of severity. Some individuals may experience mild proteinuria with minimal impact on kidney function, while others may develop severe proteinuria, nephrotic syndrome, and progressive kidney failure. There isn't a formal classification system based on specific pathological features, but the severity of proteinuria and the degree of kidney dysfunction are often used to categorize the disease and guide treatment decisions. The treatment and management of schistosomiasis-associated nephropathy involve a multi two-pronged approach aimed at eradicating the parasitic infection, controlling the immune-mediated kidney damage, and managing the complications of kidney disease. The cornerstone of treatment is anti-parasitic medication, typically praziquantel, which is highly effective in killing adult schistosome worms. In addition to anti-parasitic therapy, immunosuppressive agents, such as corticosteroids, may be used to reduce inflammation and immune complex deposition in the kidneys. Angiotensin-converting enzyme AC inhibitors or angiotensin receptor blockers, ARBs, are often prescribed to control hypertension and reduce proteinuria. Dietary modifications, such as restricting protein and salt intake, may also be recommended. In cases of advanced kidney failure, dialysis or kidney transplantation may be necessary. Prevention is the most effective strategy for controlling schistosomiasis and its associated nephropathy. Preventive measures focus on interrupting the parasite's life cycle and reducing human exposure to contaminated water. These include improving sanitation and hygiene practices, providing access to safe water sources, and educating communities about the risks of schistosomiasis. Mass drug administration programs, where praziquantel is administered to entire populations in endemic areas, have been successful in reducing the prevalence of schistosomiasis. Controlling snail populations, which serve as intermediate hosts for the parasite, is another important preventive measure. Avoiding contact with fresh water in endemic areas, especially swimming or wading, is also crucial for preventing infection. Travelers to endemic regions should be particularly cautious and adhere to public health recommendations. The prognosis of schistosomiasis-associated nephropathy depends on the severity of kidney damage at the time of diagnosis and the effectiveness of treatment. Early diagnosis and prompt treatment with anti-parasitic medications and immunosuppressive agents can improve outcomes and prevent progression to end-stage renal disease. However, in some cases, kidney damage may be irreversible, leading to chronic kidney disease and the need for long-term dialysis or kidney transplantation. Recent research has focused on identifying biomarkers for early detection of kidney damage and schistosomiasis, as well as exploring novel therapeutic targets for reducing inflammation and immune complex deposition in the kidneys. Studies are also underway to evaluate the long-term effects of praziquantel treatment on kidney function and to develop more effective strategies for preventing schistosomiasis transmission in endemic areas. The development of a schistosome vaccine is also a major goal of ongoing research efforts, which could provide a more sustainable and cost-effective approach to preventing schistosomiasis and its associated complications.